Thank you for joining us today for this ASNC virtual town hall with a focus on chest pain. I'm Randy Thompson, a cardiologist in Kansas City and the president of the American Society of Nuclear Cardiology. And with me is my colleague, Dennis Calnon, who's the president-elect for the society, takes over from me in January. Obviously, chest pain is an important issue to doctors that provide the services that ASNC supplies. Recently, in fact, last week, just a few days ago, the 2021 AHA-ACC guidelines for the evaluation and diagnosis of chest pain were published. These were long awaited. They're rather comprehensive, a very long document. We appreciate Renee Bullock-Palmer, who represented ASNC on the guideline writing committee, and also Prem Soman and Moaz Almala, who served as peer reviewers. Because of their input, we think the guidelines were much improved. They went through a number of iterations, and ASNC had a chance to review them, and the board of directors discussed them a number of times. The nuclear cardiology's value for chest pain is strongly reflected, I think largely because of their effort. And ASNC's input is seen throughout the guidelines. Again, the last iteration of them is much better than earlier iterations. I'll give you some examples of what all's in there. For example, here, nuclear cardiology is listed as a Category 1 indication for intermediate risk patients with acute chest pain and no known CAD who are eligible for cardiac testing. 2A recommendations for intermediate risk patients with acute chest pain and no known CAD, inclusive CT scan, and intermediate risk patients with acute chest pain and known CAD who have new onset or worsening symptoms. This is rather obvious. It reflects clinical practice. Also, Category 1 indication for intermediate risk patients with stable chest pain and no known CAD for stress imaging, and 2A for intermediate to high risk patients with stable chest pain and no known CAD for whom rest stress nuclear MPI is selected. PET is reasonable in preference to SPECT. So this is the first time that PET's special ability to detect disease compared to SPECT or other stress tests has been called out in any document other than something that ASNC or the other nuclear societies have written. So we're glad to see that other doctors have recognized this value that PET has. We think it's represented in the literature and our clinical practices. That is a more precise modality to use. Likewise, a 2A recommendation for intermediate to high-risk patients with stable chest pain for selecting stress MPI, the use of attenuation correction or prone imaging. This likewise is the only time that document outside of ASNC's publications have brought up the importance of prone imaging or attenuation correction. We think it is important to do high quality 2021 type nuclear cardiology. And for patients with known extensive non-obstructive disease, stress imaging is reasonable for diagnosis of myocardial ischemia. Also, PET flow was called out, likewise the first time in a non-nuclear cardiology guideline type document for patients with obstructive CAD who have stable chest pain, symptoms undergoing stress MPI or stress CMR. The addition of myocardial blood flow reserve is useful to improve diagnostic accuracy, enhance risk stratification. It's also powerfully prognostic with PET. And the one underneath that for diagnosis of microvascular dysfunction. This is a diagnosis that's being, the importance of which is growing and recognition of which is growing. Also in the text was information about the use of SPECT with coronary calcium scoring. We believe in this. We think it improves the diagnostic accuracy, the prognostic power of the study. And we're glad that it was at least mentioned in the text of this document that came from the other societies. Here's a bit of a summary of how nuclear cardiology fared in some of these recommendation scores. Intermediate risk with no known CAD, 2 Category 1 scores and 2A scores. And for stable chest pain patients, intermediate risk with no known CAD, a couple of Category 1s and a half dozen or so Category 2A scores. So the guidelines, we think in this sense, reasonably reflect the use of nuclear cardiology the way we use it today. And a lot of this that we're talking about is because of the work of the ASNC representatives that were involved in the process. So the positives are that it reflects the multimodality imaging environment. that nuclear cardiology modalities were reasonably recognized: SPECT MPI, attenuation correction, calcium scoring, and PET MPI and PET myocardial blood flow. Now, there were some unresolved concerns. The way this worked is in the spring, the ACAHA leadership sent us a document, and it was reviewed by the ASNC Board of Directors, and it was a mess. And the Board of Directors felt fully strong we could not sign it. We expressed our concerns. We read out our concerns. We contacted the other imaging societies. We contacted the American Heart Association, and the American Heart Association seemed to be more willing to re-review this than the ACC leadership was. In any event, we got a message back somewhat later that indeed it would be re-reviewed. Please send our recommendations and concerns. And so we did so. And a few months later in June, we got another document. Again, it was the vote yes or no. We still had concerns, and therefore we ended up not endorsing it. The ASNC Board of Directors felt that it could not be endorsed. It does not reflect patient-centered imaging the way we think it should. There were still some major deficiencies, although it had come a long way. Here are our thoughts about it. This was authored by the ASNC Executive Council on behalf of the ASNC Board of Directors. It's been accepted for publication in the Journal of Nuclear Cardiology, and we have posted it on Zenodo, which is a preprint server. It's available if you have not seen the link yet. If you don't have it or can't find it in Zenodo, feel free to email us at the end of the slides. We have an email contact number where we can send it to you. There were several things that bothered us about it. One of them was that FFRCT was overly prominently displayed. There's only one company that supplies that service. It's not widely available. It's reported with a temporary Category 3 code, so it's not widely covered by insurance. And there's a fair amount of dispute about exactly how useful it is in the patients that need it the most, those who have a lesion that appears to be in the 40 to 70% stenosis range. So we communicated that, and that didn't seem to change the minds of the leadership for the guidelines writers. We also pointed out that there was no mention of the limitations or contraindications. Now, every modality has limitations and contraindications. Here it is, Table 5 listed for the other 5 imaging modalities. Some of these are, we thought, not particularly subtle enough. For example, contraindication to nuclear testing and those with suspected bronchospastic disease. Well, that's a relative contraindication. We give rigodendron in patients that have some bronchospastic disease all the time. But there's no mention of the limitations of FFR-CT. And we sent to the guidelines writers some documents about the limitations, asking them to put them in there. For some reason, they did not want to. They did not. We don't know why. Here's what we sent. This is the FDA approval summary for CT-FFR, and it's fairly explicit. It gives these limitations: suspicious of acute coronary syndrome, recent prior myocardial infarction within 90 days, complex congenital heart disease, prior coronary artery bypass grafting, patients with a BMI greater than 35, patients who require emergency procedures, and due to potential artifacts, CT data might be degraded in those with intracoronary metallic stents, patients with prior pacemaker or internal defibrillators, patients with prosthetic heart valves, patients with significant arrhythmias or tachycardia, coronary vessels with excessive calcifications. It's been studied in patients with prior PCI, but the results have not been validated in those with metallic stents. And the diagnostic performance and validated patients are candidates for invasive angiography based on clinical presentation and/or non-invasive testing. There was, this document went on and on. There's also CT-FFR may be adversely affected by marginal image quality, grossly incorrect brachial pressures, regional or global myocardial dysfunction, myocardial mass abnormalities, abnormal patient physiology. Well, obviously, every modality has limitations. This modality has some usefulness. It's a useful tool in improving the specificity for coronary CTA, but we thought it had an overly prominent role in a number of documents and a number of figures, and did not have, for some reason, any of these limitations. So our response has been, we did issue a statement about our principles about multimodality imaging. ASNC does embrace multimodality imaging. That's the way we do things these days. We think every test has its usefulness, and all of us as physicians use virtually all of the tests, some more than others, but we base it on the patient's specific indications, the benefits, the downsides, and these decisions can be nuanced. We also, with the help of other societies, issued a statement on the cardiovascular test substitution and authorization. So actually, this is one of the bigger concerns that the members of the board of directors had, which is not only is this document on chest pain guidelines imperfect, but that imperfection gets amplified when, in our point of view, insurance companies and radiologic benefits managers sometimes cherry pick the parts of the document they like. So in fact, some of the insurance companies even invested in the company that makes CTFFR. So our concern was that some of this test substitution, which we find very onerous, would be exaggerated by the imperfections of the guideline. In this statement, we got all of the other cardiovascular imaging societies, including the ACC, Cardiovascular Council, to agree with this document. We're pushing back on this policy of test substitution and abusive prior authorization, driven by short-term cost savings, and we think not in the patient's interest, not in the way patients ought to be taken care of. So the unresolved concerns based on the board of directors was that the guideline does not adequately reflect patient-first imaging and patient-centered care, really our core beliefs, our core principles. That the document, although had some good things and was improved compared to prior iterations, was unbalanced, biased presentation of the science in several key areas, and the potential to be misused by payers and radiologic benefits managers to require modality first care rather than the nuance that we think the physician expert can bring to the decision. So ASNC is moving forward. I guess you would ask what next. We have a number of things in the works, a number of plans to try to help educate our members and others on the principles of patient-first imaging and then the nuances of which test for which patient. At this point, I'll turn things over to my colleague, Dennis Calnon, who can give a little more detail.
All right, great. Thanks very much, Randy. ASNC is and really always has been a patient-first organization. We're multimodality imagers, but we always try to emphasize that the right test for the right patient done the right way is the right way to go. So ASNC's priority is and always will be the patient and not the test. So we want to try to focus the conversation on what's right for the patient. Next slide, please, Randy. So this is the Patient First portal, which is available now on the ASNC website. There you'll find several videos that are very educational, including access to our multimodality webinar that we held this summer, where we really addressed patient test selection for a variety of different patients and different clinical scenarios, and tried to cover which patients benefit from which specific tests in any given scenario. So there's also tools that you'll find on this Patient First portal, including things you can use to help you educate your referring physicians on which tests are best for which patients, as well as tools that you can use if you come across problems with denials from private payers. You can go to the next slide, please, Randy. So some of the Patient First tools, maybe clicking. So the imaging and chest pain, a checklist is something that is available now, something that you can use and share, again, with your referring physicians to help them understand which tests are appropriate and which type of patient. Next, Randy. And there's also upcoming webinar series that we're kicking off in the very near future, starting with a program on chest pain in the emergency department, from cases from the Cleveland Clinic, demonstrating how we decide which patients are best for which tests and why. And there'll be more educational programs in the works to follow. One program is already planned in December, focusing on the value of myocardial blood flow measurement with cardiac PET for patients with chest pain. And there'll be a variety of other programs to come in 2020 and all throughout the year. Next. And then in terms of the patient-first advocacy, as Randy mentioned, we have the policy statement on cardiovascular test substitution and authorization, which we strongly oppose. And that's been supported by all the other cardiac imaging societies as well. And then next, Randy. There's also this form, and I think that you'll find this very useful. All of us, when we're in practice, we are frustrated by the extra time that we're wasting away from our patients and away from patient care, spending time doing peer-to-peer reviews to get approval for our testing. And when we all do that as individuals, it's difficult for us to get that message out to anyone. But what we're recommending that you do is use this tool on our website to send the information to our health policy team. They'll start aggregating the information, and when they start to notice trends where certain payers are refusing very appropriate tests for the wrong reasons, we can then have our health policy team and our ASNC leadership reach out directly to these payers and to the radiology benefit management company to try to resolve the issue. So this is something that you can use. It makes us, I think, feel a little bit better when you know you're actually doing something about it rather than just grumbling when these things come up. So we're kind of preparing you in advance for what we fear could happen as a result of the chest pain guidelines, as Dr. Thompson mentioned. Next slide, Randy. And so with that, I think we're going to start opening things up for questions from the attendees. So again, thank you for joining us tonight. We wanted to give you a little bit of an update on where things stand and why in terms of ASNC's involvement in the process of the chest pain guidelines, but why we decided not to endorse. So now we'll open it up for questions.
Yeah, please put your question in the chat box. I see we've got a couple of comments from the ASNC staff about the editorial. There's the link to the editorial that we wrote is there. One question I was asked earlier was, is ASNC planning to issue their own guidelines? And one of the surgical societies did that. They were not happy with the AHA-ACC guidelines on something they had that was important to them, and they did not only not endorse, they also wrote their own guidelines or are planning to. And ASNC is not planning to issue our own guidelines, so we are planning to do all the things that Dr. Calnon mentioned in terms of educating our members and our constituents and referring doctors, we hope, on this nuanced issue of what's the best test for the best patient at the right time.
Not a lot of other questions, Randy, but maybe you can comment just on how the board of directors did struggle with this in terms of our decision whether or not to endorse the document or not.
We did, and the key issues are one we mentioned. It didn't seem balanced. It didn't seem patient first. It didn't seem like it really reflected our core values, and the danger that when something's imperfect, it can be taken out of context, or at least we have this perception that's what happens with radiologic benefits managers. Some of the more abusive ones do that. They'll substitute a test for short-term cost savings, it seems, take the decision away from the doctor who perhaps is an authority. And the other thing that's not mentioned very much in the guidelines that we are very aware of is that there's a great variation in availability and expertise. I mean, there are places where if the nuclear that's being done is circa 2005 or 2000, and they've got superb CT, I think I would shift that toggle over to the right and be ordering more CT myself. But other places where nuclear, even MR, are really done expertly, they ought to be, the doctors correctly and appropriately order what they're good at, what they know they can do, when they know they can get the answer. A test that's done well is almost always better than another test that's done poorly.
Yeah, Randy, there's a question here, which maybe I'll take on. It talks about like the patients with no known disease and the differences between coronary CTA and SPECT myocardial perfusion imaging. And one of the strengths of coronary CT angiography is the ability to rule out atherosclerosis And so for the low to intermediate likelihood patients, we do find it useful. Both Dr. Thompson and I are multimodality imagers. I'm a member of the Society of Cardiac CT. I'm level 3 trained in CT. I'm board certified in CT. I'm a fellow of the society. So many of us on our ASNC board of directors were in similar positions where we do imaging of other types all the time. And so that's true. Now, one of the things that we found, though, is that some laboratories that are doing really modern state-of-the-art SPECT and PET imaging today are adding coronary calcium scoring routinely. Dr. Thompson mentioned that briefly in his discussion, but we think that adding a coronary calcium score to myocardial perfusion imaging really gives you the best of both. It gives you an assessment of ischemia, which we all know is extremely important in terms of predicting benefit from revascularization and prognosis. And it also allows you to detect subclinical coronary artery atherosclerosis, similar to what you would get with a coronary CT angiogram that is able to detect the mild non-obstructive plaque. So I think that we're certainly encouraging our ASNC members to begin incorporating routinely coronary calcium scoring as part of myocardial perfusion imaging. And maybe Dr. Thompson can expand on that a little bit as well.
Yeah, I agree. And as Dr. Calnon said, we order coronary CTAs. We're not knocking coronary CTA. It's a great tool in the right patient population. We think it had a little bit, the way the guidelines were written, had a little bit too prominent a role. The way the guidelines were written, it was a bit artificial, anatomic testing versus other testing. And that sort of put CT out more prominently. You don't really do it that way. You think of which test is the right one for the patient. And this approach kind of just blurred the distinctions between different functional tests. But now it's a good test. And we add coronary calcium scoring to stress tests routinely in our center. And when someone has a known coronary disease, we also look at the CT, the non-attenuated, the attenuation map for other diagnoses that you can get from the CT. And from my reading the literature, the prognostic value of a coronary CTA is mostly in the calcium scoring. And there's some literature that came out this year that kind of suggests that.
Yeah, there's another question from one of the attendees about the low-dose CT scan used for PET for attenuation correction or for SPECT attenuation correction. Is that sufficient for calcium scoring? And technically, no, it's not sufficient to actually acquire a true calcium score, but it can be useful for sort of subjective visual assessment of the presence or absence of coronary calcification and the extent and severity of coronary calcification, which can be quite helpful. But no, technically it's not adequate for calcium scoring. Typically the labs like Dr. Thompson's lab will perform and acquire separately a true calcium score as part of the
Yeah, we just elaborate. That is a bit of a complex issue. There's extra cost in machinery and software to be able to do the calcium score itself. And there's a pretty good literature that just by eyeballing the calcium on a non-gated study, low-dose attenuation map, you can get some helpful prognostic information. So if you can look at it, it's valuable to do so. In fact, even just a rough eyeball by non-experts, there's a lot of calcium, a little bit, or none discernible. Even that carries helpful prognostic information.
There's another question, Randy, about does ASNC plan to meet with the RBMs and their payers, preemptively, or wait and see what the response is to the new guidelines?
Hasn't been determined yet. We have discussed that. We'll discuss it some more. We will try to reach out to them at some point, but haven't yet anyway.
There's a question, maybe a hopeful question, that will these guidelines have any impact on the need for prior authorizations for PET imaging? Sort of hoping, I guess, that this will, nudge the payers and the RBMs towards, more broad approval.
Well, that does give us some ammunition as when we go to payers to get them to be a bit more reasonable about covering PET myocardial perfusion imaging. We don't know yet. We don't know how much this will lead to either decisions we don't like, which we think are inappropriate, or perhaps a little more reasonable decision making.
Yeah, there's another question from Dr. White about, will ASNC provide PowerPoint slides, perhaps that could be used to give lectures at regional educational venues, and certainly we're planning on making the PatientFirst portal, extremely robust in terms of lots and lots of tools. So that's something that would be helpful. I understand. And so that may be already there. But if not, that's something that we definitely can plan to provide as well. Because we want our members to spread the word to their local referring physicians and their local payers, and help us with our efforts to spread the word.
Yeah, the two conferences that Dr. Calnon mentioned, the first one on November 30th, those will be converted to on demand, and you can use the material there liberally if it helps you educate other people.
Right, and our multimodality imaging session we did in August is already available on the PatientFirst portal as well.
Dr. Charles Stone says one of our concerns is the de-emphasis of the psychological benefit, physiologic information to be gained with exercise testing alone and exercise testing with imaging. There is a text in the guideline about the value of exercise testing. And I didn't really go into it. The guideline is long, it's comprehensive. It talks about chest pain centers and troponins and when coronary angiography is most useful, how to address non-cardiac chest pain. We focused on the part that was the most interest and relevant to us. There is some reasonable text in there about the use of the physiologic information of exercise, and I agree entirely. It shouldn't be lost in this discussion. Exercise is powerfully prognostic. The fact that you can do that with SPECT is one of the real benefits over CT or MR, for example, or pharmacologic testing with the other modalities.
Yeah, absolutely. There's also a question from Dr. Better, who was wondering whether ASNC thought about maybe endorsing it with restrictions. This wasn't an option for us. Our options were to endorse it or not endorse it. We had no other options that we were given by the ACC AHA, so that wasn't an option. And we, as Dr. Thompson mentioned, we specifically gave the writing group our thoughts, including in detail all of the things we would like them to include about CTFFR to just make the guideline document a little bit more balanced in that way, and they were unwilling for whatever reason to include that. And including the cost information, I don't believe Dr. Thompson mentioned, but the guidelines go into some detail in the discussion about cost considerations for different imaging modalities and different approaches, but there's no mention in the discussion at all about the added cost of the CTFFR. It's kind of just left out, and again, for unclear reasons. So that was something else that we found strange and a bit bothersome in terms of the poor balance.
Yes. Now to go back, ask if we're aware of any upcoming publication or changes to European guidelines. There's some 2019 guidelines that address some of this issue that we quote. In fact, there's a figure from there that we actually use in our discussions quite a bit, where patients on the low pretest likelihood side are referred for either no testing or maybe CT, and those on the high pretest likelihood are referred for coronary angiography, for example, if you have an acute coronary syndrome. And that in between, CT is favored in the lower end, and nuclear and MRI are favored in the higher end, such as those with known coronary artery disease. Since that came out a couple of years ago, I don't know of any European guidelines that are pending. There are some other ACC guidelines that are in the works that sort of overlap with some of these issues, but those are the only ones we know about.
Great. I think we might be kind of caught up on the questions. If people have other questions, Dr. Thompson and I would be happy to stay a bit longer and answer more if there are more.
Here's our ASNC.org patient first, and you can contact us at info@asnc.org if you have other comments or questions, or any other things you'd like to address.
Yeah, there is one other question from Dr. White about, is there appropriate use criteria update pending? And there is in progress a document on stable ischemic heart disease appropriate use criteria, which will address a lot of the same multimodality questions that are covered here. It's a little different. I mean, I had an opportunity to serve on the rating panel for it, and so I think suffice to say for now, it'll appear a little different than what the chest pain guidelines looks like. But that is coming probably early 2022 is my guess.
Well, thank you everyone for joining us, and we'll continue the discussion. Please reach out to ASNC, and please look on the ASNC website for other communications we'll be giving as we continue this communication discussion.
Thank you, everyone.